He is Professor and Head Department of Radiology from Sri Ramchandra Medical College. I request you to take up the X-rays since it is the most important part of PG exam review.
Very good afternoon to all of you. I should thank Dr. Julius Scott and his team for organizing such a wonderful RIPE conference and asking me to present this pediatric imaging interpretation. This is very, very useful for your practice and also for the exam point of view. Because it is a post-lunch session, I thought I will stimulate your brain cells asking some questions regarding what I'm going to project. See, this is just to test your skills. Test your skills in reading this pediatric imaging. See, it will be a juggling like this, but the diagnosis will be the one only in pediatric imaging. Here is a 2-year-old female, 5-week history of refusing to walk and play. That female has got a back pain, fever, no neurological deficit, elevated white cell count and ESR. What radiological investigation will you do for this girl? First, plain, what you'll do? Yes? Yeah, plain X-ray, isn't it? First, you'll do the plain X-ray of the lumbosacral spine, right? See, sometimes, can you appreciate that spine? See here, you are seeing the vertebra, intervertebral disc. How will you read this one? You'll see the body of the vertebra, intervertebral disc space. And when you see here, there is some sclerotic area is seen. Some sclerotic area is seen here, right? What next investigation you'll do? Any investigation you wanted to do it for this patient? MRI. Before that, you can do this isotope scan. See, in this isotope scan, see here, you can see these are all the symmetrical spots. Symmetrical spots are all the growing ends. Here also the symmetrical is there. But you look at here, there is a increased uptake is there in the lower lumbar vertebra. And then when you do a CT scan, you can see this lytic lesion. Can you see the lytic lesion? That is the cause for the pain. So what do you think? Yes, what is that lytic lesion in the vertebra? Yes? Huh? Malignancy. Next investigation you'll do is the MRI scan. Here you see this. See, this is the vertebra and this is the intervertebral disc space. When you are coming here, you can see there is a hyperintense lesion is seen here. And epidurally, that is seen also. So what do you think? Correlate with the history. Correlate with the history. Yes? It is a spinal osteomyelitis. So what you have to do is, when you do this one, when you take a first X-ray, within 2 to 4 weeks, it may be a normal X-ray, but when you do the same X-ray after 6 to 10 weeks of infection, the vertebral body may be flattened, and the isotope scan will be positive within the days of infection, and a CT and MRI to see for the epidural and the paravertebral abscesses. So that is the diagnosis for that case. Another case, 11-year-old female, progressive scoliosis for 2.5 years. Last few months, developed a back pain which was relieved by aspirin. This is very important history. What do you think? Yes, yes, somebody has prompted correctly. On examination, there is a thoracolumbar scoliosis, no neurological deficit. Clinically, tumor was suspected because of progressive scoliosis and immediately, developed a back pain. What do you see here in this X-ray? Whenever you see this AP view, you see the body of the vertebra. What you are seeing here is the pedicle, and here also this is the pedicle. But when you see here, that pedicle is not seen very clearly, or there is distortion of the pedicle is there. And when you do isotope scan, you see here there is large increased uptake, asymmetrical increased uptake of the isotope is there, bone scan lab. What do you think? When you do a CT, because for a bone, best thing is to do a CT scan, right? MRI for the soft tissue, and here you see something is sitting here, that is a sclerotic area is seen in the pedicle region. What do you think? It's a painful scoliosis relieved by aspirin. That is the history. Yes, very good. That is osteoid osteoma. Any scoliosis associated with the pain needs further workup. That is, one is the osteoid osteoma, osteoblastoma. If that size is more than 10 centimeter, infection, histiocytosis, and aneurysmal bone cyst. All these can be diagnosed with the bone scan and the CT scan. MRI has got no role in this osteoid osteoma. And nidus also can be picked up. Another case, 6-year-old male, fever, abdominal pain, occasional breathing difficulty. Very important history is the string bite 4 days back. When history of string bite is there, mother is bringing with a fever and abdominal pain, what investigation you'll start? Yes, chest X-ray, isn't it? So this is immediately, as soon as the baby has come to the casualty, X-ray was taken. X-ray chest PA and the lateral view is taken. Are you seeing any abnormality in this chest X-ray? Because fever is there, history of string bite is there, you'll expect some pneumonatic changes will be there, but we are not seeing anything in this particular X-ray. Because abdomen pain also was there, so for that reason they have taken an abdomen in a supine and also in an erect view they have taken, but that also is not contributory. So next modality, they have done a CT thorax. What do you see here? See this side, this is the lung, black area, but here you see that small consolidation is there and a minimal pleural effusion is there on the right side. Okay, that is slowly developing. Once they saw that one, instead of repeating it again CT scan, they've done a chest X-ray. Chest X-ray is showing there is a pleural effusion. You see this is a pleural effusion and there is a consolidation, right basal consolidation. Left lung appears normal, domes of the diaphragm and the CPA angle is normal. So that is, when like this it is there, you suspect that is staphylococcal pneumonia. Rapidly progressing pneumonia, highly suspicion of a staphylococcal, and culture showed a gram-positive, and cellulitis from bee bite in forearm resulted in a pleural effusion and a progressive staphylococcal pneumonia. Another case, 6 months old child, right side hemiplegia, no cry immediately after birth, delayed milestones. Once this history is there, what investigation you'll ask for? MRI. Yes, you can do MRI, but for this patient, they've done a CT scan. CT, how will you differentiate the CT and MRI picture when you are looking at this? You look at the bone, brighter, it is appearing brighter means this is CT scan. When it is appearing hypo intense, then it is a MRI. Crudely, I am just telling you for this. This is what has happened here. What happened to this? This brain has developed here. There is no brain is there. And then it is open lip. Open lip. What is the diagnosis? Open lip, scissioncephaly. That is typical. See, you can see the brain is not developed. Presentation will be what I have showed it to you. So this is an open lip, scissioncephaly. This can be kept as a spotter for you people. Nowadays, very common. Fever 1 week. You'll ask for ultrasound abdomen. We'll do ultrasound abdomen. Yes. Dengue fever. Very good. See here, this is the gallbladder. And you see the sludge within it. This is the gallbladder wall is thickened. And this is the pericholecystic fluid. And next stage, what will happen? Polyserositis. Fluid may be accumulated in the pelvic region, right pleural space, left pleural space, pericardium, and both paracolic gutters. So that is classical feature of a dengue fever. Suppose if it is typhoid fever, only gallbladder changes will be there, and also we'll see the mesenteric lymph nodes. Okay? If it is a leptospirosis, we'll see kidney involvement will be more than this gallbladder will be shown, and ascites will be there, and a kidney involvement will be there in case of a leptospirosis. In that way, imaging wise, we will differentiate this type of fever. So these are all the findings in a mild form. You'll have a minimal ascites, minimal pleural effusion, and a minimal pericardial effusion. Sometimes you may get the hepatosplenomegaly. And in severe form, you'll have a pararenal and perirenal fluid, subcapsular fluid, pericardial effusion, pancreatic enlargement, hepatosplenomegaly. Sometimes because of the bleeding, we may see hyperechoic areas in the liver, spleen, or in the kidneys. Another case, young female, cough, cold for 15 days, evening rise of temperature, increased polymorphs, but normal ESR. What do you think? What investigation you want to do first? Imaging investigation? Yes? Chest X-ray. See, when you look at the chest X-ray, see what you see here. There is a rounded opacity with air bronchogram. For a curiosity, I did an ultrasound. Ultrasound has picked up a vessel within it and solid echo is seen. What do you think? This is typical of a round pneumonia. This is typical of a, see, round shape. Air bronchogram is seen. And when you do sometimes ultrasound, solid echoes with a feeding vessel is seen. This is typical of a round pneumonia. Commonly, when you are posted in newborn, you will come across abdominal distension. You will ask for an X-ray. This patient, we have done in addition to the X-ray, we have done a CT scan also. What is the diagnosis? Yes? Yes, pneumocystitis. See, this is the intestine. Wall of the intestine containing lot of pockets of air is seen. That is typical of a pneumocystitis intestinalis, right? In such cases, you always look for the portal vein gas. This is also a spotter for you people. Yes? Look at this. Arch of the aorta is supposed to be on the right side, isn't it? Arch has to be supposed to be on the right side. but you may not appreciate here, but here you see this arch of the aorta is on the right side. So it is right-sided aortic arch. So it may be associated with some of the other congenital anomalies. You have to look for that, okay? This is also 3D reconstruction of the pelvis, CT. What do you see here? Yes? Very good. Yes, what you pointed out. See here, this is the acetabulum. Here the femoral head is seen within it, but what has happened? It has come out. So what is the diagnosis? Developmental dysplasia of the hip. This is a typical developmental dysplasia of the hip. First line of investigation for this developmental dysplasia of the hip is ultrasound. Yes, ultrasound, we can pick up this one at an early stage itself. See, you see this. This is typical of a sunburst appearance. When you look at the X-ray under the MRI picture, that sunburst appearance is classical finding in X-ray is, yes, osteogenic sarcoma, osteosarcoma. When you are looking at this, what do you think? This is a clinical photograph of a child. Yes? Rickets, very good. That's a rickets. So when you take an X-ray, because usually they'll take an X-ray of the wrist, because at the crawling time, that baby started crawling between 6 to 9 months. When it is crawling, the pressure will be there in the wrist, and most of the changes will be picked up in the wrist. So that's why we will take a wrist X-ray, first wrist X-rays for all cases of a suspected case of a rickets. Here you see this cupping, fraying, splaying, and the zone of provisional calcification is increased, and bone demineralization also is there. This is classical appearance of a rickets. So findings will be loss of zone of provisional calcification, wide epiphysis, and a cupping, fraying, splaying, and the irregularity of the metaphysis, and a bowing of a long bones, and a decreased bone density, rackety rosary in the ribs, and a periosteal reaction will be there in case of a rickets. This one. These are all the classical X-rays, they'll keep it for the exam. Here you see this, and here periosteum is so much elevated. What do you think? Scurvy. Yes, very good. This is scurvy. Scurvy, you'll have a first one will be the Wimberger sign. That is small epiphysis surrounded by a sharp sclerotic rim and a subperiosteal hemorrhages. That is what I showed it there. And a white line of Frankel, dense band of growing metaphyseal involving the provisional zone of calcification, and a Trümmerfeld scurvy zone. This is that area. So these are all the scurvy features. And the Pelken spur, this pointing is the Pelken spur. And the differentiation is between this rickets and scurvy. See, you see this, and the zone of provisional calcification. Once you see that that is widened, that is rickets, here it will be normal. Newborn child, abdominal distension, X-ray has been taken. Can you see something is calcified here? Something is calcified. When you see a calcified density in the abdomen, what do you think? Yes? One is hepatoblastoma, second one is the meconium peritonitis. Meconium has been calcified, that one. So this is a case of a meconium peritonitis. This is a newborn child. Immediately they've done a CT thorax. Congenital? Diaphragmatic hernia. But see what is projecting here. Heart is outside. Extrophy. See, that is one of the syndrome it will come. So here the heart is supposed to be inside, but that is projecting out. That is extrophy of the heart is seen. Spotter. What is this investigation? MRA, very good. MRA, magnetic resonance angiography, where they contrast, sometimes they'll give contrast or without contrast also, we can see. What you see here, dilated one, what structure will come anatomically there? That's a vein of Galen aneurysm, VOC. That is vein of Galen aneurysm. And then we'll do a reconstruction, 3D reconstruction. In that we can see that nicely that vein of Galen aneurysm. So this is also ultrasound, you can see that vein of Galen aneurysm. In MRI and CT angio, you can see that cystic area is there. This is the normal feeding vessels. Yes. This is also a spotter. You've seen a lot of CT scan, CT brain. Usually you'll see the frontal horns will be close together, but here it is very far apart. When you see that bracket-like thing, when the frontal horns are all far away from that, you suspect that is the agenesis of the corpus callosum. This is also very commonly asked one, is the ring enhancing lesions in the brain, isn't it? So I've shown you the ring enhancing lesions in the brain, and these are all the surrounding edema. What are all the common conditions? Yes, tuberculoma, granulomatous lesion. Yes, neurocysticercosis. Yes. So in exam tension, you may forget it. So remember, general practitioner from Stanley Medical College. One is the granuloma, another one is the pyogenic abscess, septic emboli, metastasis, cysticercosis. In this granuloma includes that neurocysticercosis and also this tuberculomas, right? Granulomas and cysticercosis here. Varieties of ring enhancing lesion. Here you see the multiple ring enhancing lesion in the posterior cerebrum, and here also multiple cystic enhancing lesions are there, calcified one with a surrounding edema. This is typical. Plain brain scan, you're not seeing anything at all, only edema is there. When you give contrast, you see the ring enhancing lesion. That is typical of a tuberculoma. And the most common one is the tuberculoma and the neurocysticercosis, which you have to differentiate it. For that you will do MRI. See, MRI here, the calcified spot is there, and also hypointense within that small speck of calcification is there. That and all is indicating that is a neurocysticercosis. This is in the brain. One patient has expired. I did autopsy. Autopsy, you can see this is the typical cysticercosis which is embedded in the brain tissue. So this is also commonly asked. One is the different stages. One is the vesicular stage, okay, and the next one is the colloid vesicular stage. Third one is the nodular stage, and fourth one is the nodular calcification. These two can be seen in a CT scan, and these two can be differentiated in MRI scan. Nodular and nodular calcification can be visualized in this imaging. And during practice, you'll have a lot of queries in this bone age. So I thought I'll show you. When you take a newborn X-ray of the hand, how many carpal bones you'll see? Newborn. No carpal bones will be seen. No carpal bones will be seen. Only in 6 months, only 2 carpal bones will be seen. That is also hamate and the capitate. These two will be seen at the 6 months. Every year, one carpal bones has to be included in that. So remember this mnemonic, cry toe. So in the elbow, capitulum will come in 1 year, radial head will come in 3rd year, internal epicondyle will be 5th year, trochlea 7 years, olecranon 9 years, external epicondyle 11 years. 1, 3, 5, 7, 9, 11 years. So cry toe, when you want to assess the bone age, right? First you may take an X-ray of the wrist. Between 1 and 11 years, you take an X-ray of the elbow. 16, 18 years, you take an X-ray of the pelvis. 5 years, when you 5 to 7 years, you take an X-ray of the knee. Patella will be developing at 5 years. So that skeletal survey, you have to do it according to the age of the patient. Thank you very much.
Thank you very much, sir. I request Dr. Uday Kumar, sir, to hand over the memento to Dr. Beckett Sai, sir. Thank you very much, sir. We'll move on to our next session, approach to a child with cerebral palsy. I would like to request Dr. Lima Paulik, Professor and Head, Department of Pediatric Neurology from ICH, and Dr. Shubha, Professor and Chief of PICU, Sri Ramchandra Medical College, to moderate this session. And I welcome Dr. Balakumaran, postgraduate from Sri Ramchandra Medical College, to present the case.
Good afternoon. I'll be presenting a case of cerebral palsy. This is a 14-year-old girl who is coming from Ikadadangal. He was accompanied by his mother. Her reliability is good. Now came with the chief complaints of stiffness noticed over the limbs from day 10 of life and not attaining milestones appropriate for age, noticed from 3 months of age, and she was noticed to have seizures from 3 years of age. Now she is admitted in the hospital for orthopedic corrections. Since the chief complaints start from the perinatal period, I like to start from the birth history. Antenatal history at first trimester, the age at marriage of the mother was 18 years and the age of present conception was 24 years. She had one previous spontaneous abortion, but the present pregnancy was confirmed by urinary pregnancy test card at day 45. She was registered in a private nursing home and she had been immunized with 2 doses of TT. In the first trimester, she didn't have any fever with rashes, no lymphadenopathy or urinary tract infection. She has had taken iron and folic acid supplements regularly, and she was not on any other medications, and no history of exposure to excessive irradiation. In second trimester, the significant history being quickening felt at 5 months of age, and an anomaly scan was done, and the mother was told that the child was devoid of any anomalies or congenital malformations, and it was told to be ruled out. In third trimester, she did not have any of the major toxemias like pregnancy-induced hypertension, diabetes mellitus, or anemia complicating pregnancy. The growth profile scan done showed the child was having a normal growth. The mother tells that she had gained weight well, but she is not exactly knowing how much weight gain she had, and she did not have any fever or any bleeding per vaginum. The natal history, she was it was a spontaneous onset of labor. The baby was delivered on expected date of delivery. Approximately, the mother gives a first stage history labor of 10 hours and second stage history labor of about 1.5 hours. And she was delivered by normal vaginal delivery. And it was a vertex presentation, and it was conducted by a trained doctor. Postnatal history, the baby had not cried immediately after birth. The exact details of resuscitations, the mother doesn't know, but she tells that the baby didn't cry at birth and required some stimulation, and the mother was told that the baby had some aspiration and was cried only after 10 minutes, but did not require any ventilation or oxygen support. The baby did not require any ICU care and did not notice to have any abnormal movement or seizures. And the baby had irritable cry, but was started on DBF at first hour of life. As per the mom, the baby did not latch well. The irritability lasted for the first 24 hours. The baby also had feeding problems subsequently, like the baby was not able to latch properly and not able to take feeds well, but was discharged home on day 3 of life. The baby continued to be dull in home and was not taking DBF well. So the mother has also tried to express EBM and given with a spoon, but that also the baby didn't swallow. And no history of any neonatal jaundice or sepsis. The mother has reviewed along with the baby on day 7 of life with the same practitioner who has advised the child to be normal. Then she had the chief complaints of stiffness, which she noticed on day 10 of life with scissoring of legs and predominantly difficulty in changing the low diapers. Then she had noticed the stiffness also of the upper limbs at 2 months of age, noticed that all the limbs were equally affected and there was no asymmetry, but now the stiffness has comparatively reduced with regular physiotherapy. Developmental delay. She also gives history of not attaining milestones appropriate for age, noticed from 3 months of age. She does not give any history of any regression of milestones. Going on to the individual domains, gross motor, child attained partial neck control at 2 years, was given later a cervical collar at present with which she is able to hold well and to turn around momentarily. And child was not able to sit, so she was provided with shoulder bases and back support with which she is able to sit with support and reach and hold objects in sitting position at 5 years. Rolling over is still not attained and not able to stand. The interpretation of gross motor domain is developmental age of 6 months with a chronological age of 14 years. Fine motor, the hands remain predominantly closed, which notice at 1 month and is always predominantly closed and fisted. She was able to grasp objects at 4 months, and now she is able to reach objects with right hand at 1 year, and still she is not able to transfer to the other hand. And she has an immature pincer, but mature pincer grasp is still not attained. So she has a developmental age of 6 months as compared to the chronological age of 14 years. Language, the baby was able to coo at 6 months and had started to do monosyllables at 1 year and now is able to speak bisyllables with a developmental age of being 9 months. Vision and hearing, grossly the child is able to recognize objects and person and follows objects 180 degree in a supine lying position and responds to sound when called by name and even from behind. Social, she recognizes her mother, shows interest in surrounding, responds to own name with a smile, laughs when laughed at to the child, and she enjoys social interaction, but she is not able to feed self or follow commands, and bladder control is still not attained with a developmental age of 10 months. For all the developmental delay, she is attending special school where physiotherapy, special braces, and mobility aids are provided, and speech and occupation therapy was also initiated. Following all this, the mother feels the child's activity has shown some improvement. The mother also noticed the child to have global developmental only, ma'am, because
I think the audience has also, you have to interact. This is not a pretty new one. In each and every meetings, this is taken, and cerebral palsy is a case which is being discussed in all your classes. So, why there is a need to hear or ask the developmental history in all the domains? What is there if you don't ask for social and adaptive or mental milestones? Yes, please.
because usually in CP only motor milestones is predominantly being affected, but also social.
The audience. Suppose there is a predominant motor developmental delay alone, whereas the mentation and other things are normal. Do you call it as a CP? No. You have to rule out the neuromuscular problems, is it not? Similarly, when the social and adaptive milestones are predominantly affected and the language milestones are affected, whereas the motor milestones are normal, then your diagnosis will be pervasive developmental disorders rather than a cerebral palsy. And if it is only a pure mental milestones delay, whereas the other things are normal, then it is a pure mental retardation rather than a cerebral palsy. So by and large, if there is a global developmental delay, then you will be thinking in terms of cerebral palsy. Of course, you know pretty well in hemiplegic CP as well as in diplegic CP, the incidence of MR is less. But in a larger perspective, suppose there is a global developmental delay, then only you will be thinking in terms of cerebral palsy. Of course, in cerebral palsy, the major problem is the motor disability or the motor impairment. And again, to ask you, what are the causes for developmental delay? Yes, audience?
It could be either because of
Yeah, please.
genetic causes.
Pardon me?
Genetic causes can be
Genetic
one.
causes. What are the genetic causes? You just name the diseases.
Down syndrome,
Yeah,
chromosomal
chromosomal
anomalies.
disorders. Yes. Fast.
Child.
Then what are the other causes?
Endocrine causes because of hypothyroidism.
Mainly hypothyroidism, yes. Inborn errors of metabolism or otherwise. Hereditary disorders of the hereditary metabolic disorders, yes. Next.
Any other things in the brain, malformations?
Any congenital malformations,
Yes.
neuronal
Developmental
migration
anomalies of the
disorders,
central nervous system. Anything else?
congenital infections, starch
Very good.
infections.
Starch infections, yes. Pardon me? Mitochondrial disorders, peroxisomal disorders, all those things. Anything else? Suppose the child is having a congenital cyanotic heart disease, do you expect the child to develop normally?
Chronic hypoxia itself can.
Yeah. Any chronic medical, general medical illnesses. Anything else?
Anything about nutrition?
Yeah.
Child with PM, failure to thrive.
Very good. Anything else? The environment is not at all that much stimulating. Say, parental disharmony, unwed mother, single parents, so many things are also there. So these are the causes for developmental delay. So you have to think about all these things you have to keep all these things in your mind. And whenever you are confronting a case of a global developmental delay, especially with motor disability, then you have to think about cerebral palsy. Of course, you know all the causes or the risk factors for cerebral palsy. Yes.
In this child, the mother was also noticed the child to have a small head at 6 months when compared to the elder child. For evaluation, a neuroimaging was done and was told the brain was underdeveloped. And the mother also has noticed the child to have feeding difficulties, predominantly for solids, but the child is able to have liquid and semi-solid smash foods in propped up portion, which is fed by the mother. She also has history of drooling and regurgitations, and also had episodes of aspiration requiring hospitalization in the past. And the child takes a long time, almost 1 hour, to take a small meal and has poor weight gain.
So why do you think she has all these problems?
Because children with cerebral palsy usually can have oromotor discoordination. That is one thing. And because of there can be bulbar palsy or pseudobulbar palsy, because of which the coordination is not so good, and the drooling of saliva, and the palatal coordination is also not so good, for which the child cannot be able to feed. And generally, most of the CP children would have mental retardation, and generally they are in a subnormal state, so they are not able to coordinate well also.
Do you think it is due to pseudobulbar palsy or bulbar palsy?
It's usually because of a pseudobulbar palsy.
Pseudobulbar palsy. You know pretty well bulbar palsy is a LMN or a UMN?
LMN.
LMN. Okay, in cerebral palsy, you have only the pyramidal tract is involved, or in the extrapyramidal system, the extrapyramidal tracts are involved. It is not the LMN. So it is the associated pseudobulbar palsy. Okay, fine.
Seizures. The first episode of seizures was at 3rd year of life, which was a GTCS with upward gaze and LOC, which lasted for 1 hour. It was not associated with any fever during the episode, was started on oral anticonvulsants. Following treatment, the child continued to have repeated episodes once in every 3 months, for which the drugs were gradually increased, and now at present child is taking 3 drugs per day, 1 in the morning, 1 at the night, and the drug compliance is good. The seizures episodes have relatively reduced. The last episode of seizure was 6 months back. And the child still not attain bowel and bladder control. The mother has trained her to micturate on Harley periods, uses diapers at night, and no history of recurrent urinary tract infection. But the child is able to signal with a cry after micturition and defecation, which helps the mother to keep the child in proper hygiene. The child also has history of constipation and passes stools once in 2 days, for which she is requiring laxatives intermittently. Cranial nerve history, the child is not able to appreciate smell. Child is able to see and follow objects, and no abnormal eye position or movements noticed by the mother. She is able to clench teeth, and there is no deviation of angle of mouth. There is no hearing difficulty. She has history of drooling of saliva.
So how do you ask for hearing difficulty?
Like predominantly when we ask that we should not be standing in front of the child, and usually from a when the child is not able to visually see us, we create a sound, either if it's a small child with a bell.
No, history-wise, how do you ask the mother, like...
If I ask the child whether, because she is in a different place, and when she calls by name, the child turns towards the mother and appreciates the mother. And it's not only by visual stimulus, which is predominantly by this auditory stimulus, so the hearing should be normal.
And also, supposing the child is sleeping or this one, any loud sound, whether the child immediately gets up. And the child mother speaks from, say, not in the same room in front of the patient, you do not know whether it's auditory or a visual stimulus. So the mother is somewhere else and she gives a call, and immediately the baby becomes calm or is able to respond. Then you ask, hearing. But mother says in front, I'm calling and child is looking, is not auditory.
And the mother does not give history of any nystagmus. The child does not have any sleep disturbances. She is able to perceive sensation like warmth and cold, and appreciates pain, and there is no behavioral abnormalities. Presently, she was admitted in the hospital for suspected right hip dislocation, but asymptomatic at present. And for also anemia, she had required 1 Paxil transfusion. Diet history, predominantly she takes only liquid and semi-solid diet. Calories, she has a deficit of 900 kilocalories and a protein of 17 gram. But for this problem of calorie deficit, she is advised on thickened semi-solid feeds with high calorie diet, but still the child has not met and still has undernutrition. And she is immunized as per national immunization schedule. The family history, she is the second born. The parents and siblings are aware of the prognosis and the complications of the child and the need of long-term care. And socioeconomic history, they belong to grade 4 according to modified Kupasamy classification. The per capita income of parents is 1,200.
You can go to the examination if there's nothing.
Yeah, in the history itself, you can summarize the history. And I am not interested. I am more interested whether there is any other sib is affected, or the other sib is normal.
The elder sibling is normal, ma'am. The elder sibling is normal.
Okay, to summarize the history.
This is a 14-year-old child who is second born to a non-consanguineous parent with delayed developmental milestones and having significant stiffness and paucity of movements, for which child has been receiving physiotherapy and also having seizures on anti-epileptic medication. I would like to think in terms of non-progressive motor disorder, probably a cerebral palsy of spastic type.
Here I would like to have a global developmental delay. And again in the history, anything else? And there is no need to say that cranial nerve history, sensory system history, like that. The history should be like a flow, like telling a story. Okay. Anything else in the history itself? What are the things you shouldn't forget when you are presenting a child with cerebral palsy? You are telling extensively about the developmental history, very good, as well as this prenatal or antenatal, natal, postnatal histories, good. Apart from that,
comorbid condition.
To tell you that whether there is any quadriparesis or not, what is the extent of the lesion, or whether it is a diplegia or a hemiplegia or a quadriplegia, we need to have whether there is any weakness of limbs. If there is so, then what is the distribution of weakness? All the 4 limbs are involved, or only 1/2 of the body is involved, or only the lower limbs are involved. Next, to say that it is a spastic CP, There must be the history of whether there is any history of stiffness of the limbs and or flailness of the limbs. Of course, he has mentioned that. Anything else? Anything else? And in the cranial nerves also, it's not necessary that you should mention she is able to smell normally. That is your observation, that is not the history. So you know pretty well what are the cranial nerves which are commonly involved in a cerebral palsy.